connectivity, or you could improve the relationship with a trusting relationship. The evidence such as is doesn't seem to support that. So I'm going to talk about our individual parenting work, group work, and then fostering as the final big gun, if you like. So this was a girl who had been rather abused. She was adopted by her adoptive prospective mother aged 7, but she couldn't let her out of her sight. The girl followed her prospective mother to the toilet even. She wouldn't even let her shut the door in the toilet. She's very anxiously attached. And so the mother was about to say, I'm going to give her back to the agency after 6 months. She's not getting any better. And she'd had various play therapies and talking therapies. But actually our formulation was that she gets so anxious and then the mother comforts her that she never learns independence. So that is what our treatment had to be. So let me show you how anxious this girl is.
Right. What we'd like to do first of all really is just, get you playing together for about sort of 5 minutes, and we're not going to interfere or even say anything. 5 minutes.
How do I get this to show?
And then later on we might just make 1 or 2 comments. Yeah, not mind with the earbuds. So
you see, I haven't changed my trousers in 10 years.
Put it on your hand, yeah. Well, you can have a go at the end, that's usually what we do. If you pop that in your ear, what does it do? No, it doesn't hurt me. What it is a little earbud. You explain to her what it is, so she knows what it is. Don't worry. Don't worry, it's not going to hurt at me. All it is a little earbud. Which way does it go? Thin end down. Right.
What's it doing?
It's a little tiny.
Why is it making
I'm putting a microphone in the mother's ear, but the girl is already very worried.
Yes. Yes. Okay, so that's great. Talk to me. What can we do? Just talk to me. Don't worry. So there we go. I'm not taking you out. Stay with you. Alright? So we've got some toys and things. You've got your book. And we'll leave, and as I say, it's just 5-10 minutes. You probably won't need it. And then we'll sit down after that. Alright? Okay. And then I'll come back in about lovely. 10 minutes full call. Alright. Okay. There we go. What are the others? What are we squeezing?
Sorry.
It's alright.
Mommy. Mommy, I'm not taking Mommy.
Is that okay? Is that okay? Let's go. I'm going to some toys. Come on.
So now I'm telling the mother to ignore the distress and distract her by playing.
What should we play with? Come on, see what you can do.
I'm going to tell you what to do and what you want.
Come on, let's have a look at this. Look. Whoops. Oh, you're playing hotel. Playing hotel. You was wanted like it. You was wanted like a little house, didn't you? Have a house. There we go, look, look. Look, actually, look at her hair sticking up. Look at how lovely skirt there. What should we do with it now? I'll tell you what, you can dress one of them, and I can dress the other one, we can put them in the hotel.
So gradually her level of crying is going down, and I'm instructing mother, ignore the crying, distract her, which is hard, because as a parent, as a mother, you think, oh, she's upset, I want to comfort my baby, my 7-year-old. But in this case it was not helpful, and it was not a generalized anxiety disorder. She was fine at school. She could even do sleepovers, but it was an attachment thing. And it's difficult, so you have to coach the mother to get out of what I call the attachment domain into an everyday life or a disciplining domain. So she came back 2 weeks later after being told to, said, I can't do it. I feel it's going to damage my child. So I then had to talk to the theory to the mother, saying, it's not going to damage her, she's not going to get an epileptic fit or be ruined inside. And then she said, well, I think she could be being manipulative. I said, I don't think it's conscious. She says, we had long discussions for an hour about this problem, but it doesn't seem to help her. I don't think it's very helpful explaining all these things. It's the way you behave in the relationship. So having then explained that to her, she was happy to carry on, and this is her 3 weeks later. This is me on the telephone, pretending to be her mother's friend, because this was a very difficult situation.
That's gorgeous, darling. Really nice. Yeah. Yeah. Yeah, that's great. Yeah. I'm going to put some nice, maybe a ribbon in my hair, perhaps.
Yeah.
Yeah.
So I'm encouraging the mother to give a little love darts, as I call them, so that the girl knows she is kept in mind.
Yeah. 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 Okay, yeah, all right then. So I'll call you back later on, maybe. Yeah, all right then. Okay. Yeah. What are you doing, darling?
I'm just waiting until it's in so I can ask you which ribbon you want.
Oh, okay, that's very nice. You won't be a moment anyway, thank you. Yeah, okay.
So did you notice she's calmer? She's now getting a secure base. She said, I'm waiting for you to finish your phone call. Before she was so jealous of her mother talking to somebody else. So this way is one way of treating this particular kind of attachment problem quite quickly. And I'm pleased to say after that the mother felt she could adopt this girl, and they have now been living together happily for several years. Okay. So then there is a question whether we do ordinary, more behaviourally based group, whether that would increase sensitive responding. So we use the same videotapes in a trial called the Primary Age Learning Study in a very culturally diverse part of London. The majority were West African or of Indian and Asian background parents. And sensitive responding did increase pre to post, although the security rating by the dog they did not. So the control group are in the front, they're getting slightly less sensitive 1 year later, but the intervention group in the background are becoming more sensitive. So you can teach sensitive responding even a bit older, and other people have shown this. So last of all, I want to talk to you about whether once you have had early abuse, is it finished? Can you ever learn to trust and love again? Some people would say the first 1,000 days are so crucial that it's pretty much all over by then. You are damaged. I have psychoanalytic colleagues, some of them are very good, but they say they're damaged inside. It's not very nice to be damaged goods, is it? So the question is, could there be potential for recovery? So then we took 50 fostered children, and who'd been for about 6 months with their foster carers, late place, age 7, after a lot of abuse. The parents were drug abusers in 90% or severe depression. And they'd usually come into care for neglect and abuse. That was the reason. And we had a control group. So it doesn't really matter, but they had about 5 times the level. So normal population, white bars, our population, grey bars, and the national Robert Goodman's adoption study, the orange bars. So they're typical of abused children who come into public care. So now let us look at whether this instrument works. So let's take that same boy. The first one was actually his foster mother, the one who said, she's there for me when I'm sick all over the night. Let us try and see what he is like when he is talking about his birth mother.
Right, okay. So, Jordan, this is an interview about you and your family. I'm going to ask you some questions about yourself first, and then I'll ask both of me.
Yeah.
Mum, but That next one. Now,
Why?
did you ever meet him?
No.
Maybe you've never seen him. Can you tell me 3 words to describe what it was like to be with your mum, your birth mum?
Upsetting.
Okay. Upsetting.
Angry.
Hungry. One more?
Worried.
Okay, so the first one you said was upsetting. Can you tell me about a time when you felt that it was upsetting to be with her?
Because she used to hit me.
Okay.
Next one.
That next one. No, what? Okay, how did it feel when she hit you?
Bad. Next one.
How do you think she felt?
I have a clue.
Okay. Next one. Yeah, next one you said was angry. Can you tell me about a time when you felt angry being with her?
Because she let me down so many times.
Can you think of a specific time? Or just an example that stands out?
Next.
She let him down so many times.
Because I told you this.
What, angry? Okay. And how do you think she felt?
I felt angry.
You felt angry, yeah. And how did
Next.
your mum feel?
Disappointed that I was angry.
Angry, okay. And the last one you said was worried. Can you tell me about a time when you felt worried with her?
No. Because she used to take drugs, so that worried me a bit.
Okay. And how did it feel then?
Upsetting.
How do you think your mum felt?
Happy.
Okay.
Excellent.
So I find it painful each time I watch that he's disappointed his mother was never there for him. She was taking drugs, so he knew that she felt happy. So secure or insecure? Insecure. She's not there for him. And that shows that this instrument is quite good, I think, at detecting what it should detect. So this is the attachment security to the birth parents between children who've been abused, fostered. So the fostered children, so the normal kids were at least 60% secure to their mother and about 44% to the father, whereas in the abused ones, 0% to the father and only 10% to the mother. So as you might expect, they do not trust abusive parents. But the big question is, can they learn to love again? Can they learn to love foster parents? And actually, this is within. So again, the birth parents, this is with the same person. The red bars are to their birth mother, and this is to their foster carer. So they're indistinguishable from normally developing kids who are not all secure. So they could learn to become securely attached again. So foster care is a very good treatment for insecure attachment when you've had abusive parenting. What was associated with security? A longer time getting the good stuff, and we videotape the foster carers with the warmer, more sensitive caregiving. Those are the two main things. So we found that foster care is quite good in England, actually, and you can form new relationships even when you are late placed. And the more you can make the more sensitive foster carers have more secure kids. And by the way, the abused kids, we were hearing about this morning from Paul Planer, you and I have this session of a high cortisol to get going in the morning, and we go down at night unless we're listening to the disco birds on the Nile. And the abused ones, there are two patterns actually, a chronically elevated or a flattened, burnt out one. But again, the good news is that foster care reverses this. After 6 months, they're back to a normal cortisol secretion pattern. Last of all, to say, even if you're in a foster care group, we have groups for foster carers to try and make them even better. We've developed a program called Fostering Changes. It's 12 sessions of 2 hours. The foster carers come. We did a small randomized controlled trial with 113 kids split in half from 60 foster carers. I love simple research. This is a pen and paper. What is the worst problem? wetting the bed, shouting at me, not playing nicely with his brother. I have a 10 centimetre ruler, 0 at one end, not a problem one end, couldn't be worse at the other, and the parent goes. At the end, after 3 months, you give the same thing, see where the line is. Nice, simple, personalised research. After all, what matters to the parents is their particular problem. I don't think you'll hear them on the bus saying, I'm so pleased my SDQ score went down 1 point. They're interested in their personal problems. And in this RCT, again, the control group are in the blue bars at the back. The intervention came down significantly, so they had fewer problems. We couldn't find a good instrument that's quick to feel for attachment, so we developed our own thing called the Quality Attachment Relationships Questionnaires. Questions like, do they come to your help if they are stressed? Do they come close to you? Will they talk in a confidential way about what's worrying them? Will they let you hug them? Will they hug you? Can they accept praise? So this is what we asked. So for short, it is the quark. I like that because in subatomic physics, the quark is the heart of the matter. It's the heart of all being. So I thought this is a nice name for this. And this morning, your distinguished professor who had 60 years of psychiatry was talking about me being a tall psychiatrist and was I good at basketball. Another reason I called it a quark is because that was my father who was a physicist. But this son of mine is even taller. I'm very upset. He's 2 millimeters taller than me. But as your colleague suggested, he is very good at basketball. This is him with his basketball team. Easy to see he's the only whitey boy in the black team. And I could not do the maths, but he is also a theoretical physicist. That is the Large Hadron Collider where he works in Geneva. And I can't understand those equations of either my father or my son. So I thought I'd put that in with the math comment by your colleague. Okay, and so would this program improve attachment? Yes, attachment improved as the parents measured the child. And the carers did say his ability to talk about his feelings, his response to praise, he can accept boundaries. And they said, I feel more confident as a parent, as a foster carer. I've learnt new skills. And these are not just selected, they did not say any negative things, I promise you. So, that's it. Thank you very much.
Thank you very much, Professor Scott. I think we had a lovely plenary today. Brainstorming. So I think we will move into our next session.
Shall I get started or?
Oh, yeah, yes.
Shall I get started? Mr. Chairperson.
Can we
Shall I? Shall we get started? I think everybody who's here must be resilient enough to stay that late. So it's a segue to talk
It's our pleasure to introduce Dr. Malouf. Dr. Malouf is a close friend, classmate, and my boss. He's the chairman of our department. And he is an accomplished child adolescent psychiatrist, and he's done lots of research, and he is also a teacher, mentor, and very prominent psychiatrist in Lebanon. So it's my pleasure to introduce him.
Thank you. Yeah, it's almost 5, so thank you for staying that late. And as I said, I think you guys are probably the most resilient in the group to be able to bear with us. So those of you who were here this morning, you may have heard me speak about the burden of mental illness in children and adolescents. in the MENA region, but more specifically in Lebanon. And I want to show again this slide where it tells you that 25% of Egyptians, and here it's adults, not kids, suffer from mental illness, and 25% of kids in Beirut suffer from mental illness. Reminding you all in the room that 50% of mental disorders start by age 14, and that at least in our context, 6% of kids who needed help and who had, 6% of kids who had a mental disorder had ever sought help, which means 94% were not getting the help they needed. So when we had this finding, we started thinking about ways to reach kids who were not receiving any kind of help. And although they were not receiving any kind of help, some of their parents were considering that their kids needed help. So these parents, 38% of kids who had a mental health disorder, their parents thought that they needed help, but only 6% got it. And I showed this morning. One of the main barriers was availability of services. This is from the WHO, and this is in Lebanon. And you can tell in Lebanon, when it comes to child mental health services, we are around 3 child and adolescent psychiatrists in Lebanon, population of 4 million people, 5 million people with refugees. You have a lot of adults, not a lot, we have around 50 adult psychiatrists, 50, 60, some of them see kids. We don't have a specific child inpatient psychiatric unit. This is almost 10-year-old now, but at least according to this paper from the WHO, or this report, you have 10 outpatient mental health facilities, only 30% of them were open for kids. And you have 3% of all inpatient beds open for kids. So there is a shortage, and even when you as a parent wanted your child to see somebody, you couldn't because of availability, of the lack of availability of services. So, and then there was this whole movement of MH gap and bridging the gap, the treatment gap. And then we thought, why won't we reach kids where they are? And the natural environment where kids are is schools, right? And there was this, also timely paper by Dr. Patel about improving access to care for children and adolescents with mental health disorders. And it really describes how task shifting plays a role, how integrating mental health services within primary care clinics, and how really school mental health services can help bridge this gap. So, kids are at school, it's a natural environment, natural setting for them, they're there 8 hours a day, so we researched the literature, applied for a grant, and got lucky to be funded to conduct a study, which is school-based, primarily looking at translating, validating, and testing an Australian intervention called the FRIENDS program. And it's a cognitive behavioral intervention given over 12 sessions, around 50 to 90 minutes long each. It was written in English, but it's been translated in other languages, and it's been tested in low-middle income countries as well, such as Brazil and Mexico. And it was endorsed by the WHO as best practice for prevention of anxiety disorders. It comes in different versions, so you obviously have the version for the youngest and the older age group. We were interested primarily in testing the one that primarily targeted adolescents. So, and our target symptoms were symptoms of depression and anxiety in a sample of students attending middle school in Lebanon. primarily were interested in grade 6 students. And in addition to testing the effectiveness of the intervention, we were also interested in looking at the implementation. And we had a lot of measures to look at the fidelity, the dose, acceptance, the reach of the intervention, because it's a new one. And you know, it's important when you translate and adapt an intervention to look at whether or not it's accepted by the parents, teachers, and students, and whether or not also there was fidelity, whether we were giving what the intervention is about. Now, for the implementation component, I will not present the data on the implementation component, but you know, we did conduct focus groups with parents, focus groups with teachers, focus groups with kids, and we asked them a lot of questions about the actual, they're on the receiving end, right? So the actual impact of the intervention. And we learned a lot from them, and now we're in the process of, you know, designing something based on this intervention, something that would better answer the need of the population. But let's focus on the effectiveness of this. So we partnered with colleagues from Harvard Medical School, and we were funded by the Global Health Department, Global Health Delivery Department at Harvard. And you know, we're a large team, colleagues from public health and colleagues from other psychologists, psychiatrists. So we recruited 10 schools, private schools in Lebanon, and we randomly assigned 5 of them to receive the intervention and 5 to act as waitlist and controls. You know, we told them, you know, if you were to be assigned to a control group, if the intervention is proven to be effective, we will ethically deliver the intervention to your school at the end of the study. And this is what we ended up doing. Actually, we ended up delivering it to 3 out of the 5 schools, remaining schools, because 2 of them elected not to receive it because of scheduling issues. And we had 4 time points, so we had a baseline before the intervention, immediately after the intervention, 6 months after, and 9 months after. I'll present some data immediately after the intervention, which luckily we got accepted 2 days ago in prevention science. So we've been working on this manuscript for the past several months, and now we're looking at the longer term data. So I'll present some of the immediately after intervention data and some longer term data as well. So we had self-report measures, and we had parental measures. So the kids filled out their own SDQ, MFQ, and SCARE. And again, MFQ because we're interested in depression specifically, SCARE for anxiety, and SDQ for general emotional symptoms and other hyperactivity and conduct symptoms. This is the actual workbook. I'm sorry, this is the manual for the leaders. So my friends use Skills for Life. These are the acronyms for the actual skills that the kids would learn during the intervention. F for feelings, R for relaxation, I for inner helpful thoughts, which is, you know, challenging your cognitive distortions. Excuse me. E for problem solving, reward yourself, practice, do it every day. And this is our translation. This is the actual workbook. So أصدقاء الشباب المهارات الحياتية. what we did, in addition to translating it to Arabic, we did some cultural adaptation. And by cultural adaptations, we did do some modifications to the names that were used to make them more cultural and relevant to the local context. We also changed certain things. For example, in the original book in Australia, when they asked kids to engage in rewarding activities, they asked them, for example, to go surfing, and our kids typically don't surf. They may play basketball, so we put basketball instead of surfing. We replaced, kangaroos with something else that our kids do see. Some of our kids never saw a kangaroo. I never saw a kangaroo myself. So, we made these modifications. And we also did make less references to politics and religion in the book itself. This is an example of a modification. We replaced some, Australian artist with Fairuz, who was more of a local person, and Maxime Shaya, who was an athlete who climbed Mount Everest, one of the first Lebanese athletes. I'm very sorry. I'm recovering from a flu, so not flu. Maïsiede is another answer. So this is from the activity book. This is one of the lessons on recognizing emotions. So, for example, you divide kids in groups, and you show them, different facial expressions, and you ask them to match these different emotions in Arabic to the different facial expressions. And another activity was, for example, about regulating your emotions, and we give the example of the thermometer. And this is where kids learn, the intensity of their different emotions and where to intervene and use the coping skills before it becomes too late. This is another example of the actual CBT. So you have the situation in the middle. For example, حصلت على علامة منخفضة على امتحانك. And then you have the actual red thoughts using the traffic light analogy, and you have the green thoughts, and here are the red thoughts, and and you could actually replace them with more hopeful thoughts, which are here the green thoughts. Here are the red feelings, break them with yellow with green feelings. Why did I say that? And here are the red behaviors, and you could replace them with green behaviors. This is an actual, cognitive automated thought, and we encourage to change with asking them leading questions. Can imagine, I have to say that actually we were the ones who delivered the intervention, not the teachers. This intervention can also be delivered by either school counselors or teachers if they're properly trained. And we are in the process now of, doing the same intervention in a younger age group, but through the teachers. So we train them, they're delivering it, we observe, rate them, and give them feedback. This is the implementation team. This is me giving a session to the parents on orientation. As part of the program also, there are 2 parent sessions. I gave the first one, and we used it as a recruitment session also for the research study. This is, one of the trainers, and this is one of the classroom. You could tell that, some of the schools that were so we excluded schools that have where the students were primarily from high social class. So we excluded schools that have tuition fees in the upper range and the lower range, the 25% high tuition fees and the 25% on the lower end of the tuition fees. So these are schools where kids come primarily from low to low middle income class. There were sessions also on friendships and relationships, and now the juicy stuff, the results. So what we showed, so I should tell you the sample size somewhere, but it's in the 250 something range. We had 50% girls, and these are the demographic of the sample. Some of them had sought mental health help, around 10%. So the sample size is 277. 144 was in the experimental group and 133 in the control group. So the first outcome measure with SDQ emotional, and SDQ emotional really looks at emotional symptoms, combination of anxiety and depression. And this is immediately post-intervention. We had what we call a time-by-group interaction, and in the orange you could see that the improvement in the SDQ emotional for the intervention group was steeper, and which tells us, you know, the kids in the intervention group were more likely to have improvement in their SDQ emotional score. But also, kids with the control group somewhat improved without doing anything by us. And some of these kids were really so hungry for some connection. So just by us showing up, recruiting them into the study, asking them to fill out questionnaires, giving them envelopes to take home, and checking on them whether or not they brought the envelopes back. All of this, I think, may have done something with these kids. And there was also the orientation session for the parents. So, but this did not last. So at 6 months, kids in the control group were almost back to baseline in blue. Kids in the intervention group continued to improve, but to a lesser extent as if it plateaued. Now, interestingly, we divided them into 3 groups at baseline. So those with high SDQ at baseline, middle range SDQ, and low SDQ. And you could see in green, it was mostly effective in kids who had were at high risk at baseline. And you know, most interventions are effective in individuals with high risk at baseline, and we did show this over here. It wasn't necessarily very effective in the groups who were at low risk or showing no symptoms at baseline. And we showed this here as well. So if you look at anxiety at baseline and depressive symptoms at baseline, you see that those who had high anxiety versus those who had low anxiety at baseline, the difference was mainly in the high anxiety group rather than the low anxiety group when we divided them based on scare. When we divided them based on the MFQ at baseline, the difference was primarily in those with the low depression score. In other words, you know, you improve in your emotional symptoms if you are at high risk for emotional symptoms, but specifically if you are at high risk for anxiety and at low risk for depression. If you are at high risk for depression, you may not improve as much in using this intervention. When we look specifically at depressive symptoms, we also had some positive findings at post-intervention. And when we look at specifically anxiety symptoms, we had some gender interaction with gender. So it was the girls who primarily responded to the intervention on the anxiety measures. Why? We're not sure. Is it because the girls in general at a higher risk for anxiety, and we did show that those who are at high risk for anxiety are the ones who improve? Or is it because the boys are too disruptive in the classroom and they really did not get what they needed to get from the intervention? And some of our facilitators were having difficulty actually reaching some of the kids in the class. 5 minutes, right on time. Thank you. So, and then we asked in the intervention group, regardless of the control group, what predicted improvement? So, how can I tell which kid is going to improve or benefit from this intervention? So, when we look at the change in SDQ, emotional, these are the variables that were significant, and I think all of them would fit under high risk for mental illness, right? So, if you have a family member with psychiatric disorder, if you've ever sought help for mental health, or if you have a high emotional, baseline SDQ emotional. And then we put them together in the final model, and these two remain the most salient. Now, I have a couple of slides just to show you the implementation evaluation data. It's not the focus group. We had, in addition to focus groups, we had questionnaires. So here it's the students, and these are questions. I liked the program. I learned new things. I found it helpful, etc. And you could see that most of them, either agreed or strongly agreed with these questions. These are questions to measure acceptance of the program by these students. This is, we asked them at the end to just place a happy face, neutral face, or a sad face about the session. And for session 1, for example, you could see 78% were satisfied, 14% were neutral, 7% were dissatisfied. So you could tell that, that we had a dissatisfied group. It was ranging between 4 and 10%. So as I said, from the focus group, we learned a lot of things, including, it's very difficult to provide these, meet all the objectives within 45 minutes, which is the typical period within the academic schedule of most of our schools. And we learned some other things as well, which we're trying to address in our hopefully next study. But I think training the teachers is important. This is in a training workshop that we gave. But also training some parents to foster resilience in their kids is as important as well. And we have, in Lebanon, some NGOs who are championing these efforts. We're partnering with this specific NGO called Focus. In this study as well, we're looking at cognitive measures as predictors. So we're testing these kids. I'm interested in cognitive measures. So we're testing these kids at baseline and allowing them to undergo the intervention, and we're going to see whether or not we can identify a profile that could predict or help you match specific kids to specific interventions. We also studied now the impact of these interventions on other variables other than mental health variables, such as bullying, academic performance. Does it mitigate risk of screens, for example? So I conclude by saying that there is a high burden of mental health disorders in adolescents in Lebanon and the Arab region. There is a wide treatment gap. School-based interventions offer a promising way to bridge this gap. Not all kids respond equally, so be aware that if the kid is very depressed, he or she may not respond. And maybe resilience building goes beyond improving psychiatric symptoms, and it would improve your overall functioning in general. Thank you.
Thank you very much indeed, and thank you for keeping to time so perfectly. Even though we're running late, that allows us to not run any later. And next, Dr. Sama El-Ab, who, apart from meeting at dinner, I do not know very much about, but I know she has worked in the UK and is currently working in Dubai, I believe. Did I remember correctly from dinner? So I'm sorry not to give you a more lengthy introduction, but we're going to continue on the same theme of mental health in schools. And if there's anything relevant for you to add, Dr. Sama, please do further introductions.
So many feel very overwhelmed and lack confidence when it comes to dealing with mental health and emotional well-being of children. These issues in the classroom. This aim, the aim, this, sorry, I think I, something else. Teachers need help and support in order to create a classroom and school environment where children can thrive with good mental health. I ran a community service in southeast London, and it was a neuropsychiatric service, and we had, and I ran a big service for children with attention deficit hyperactivity disorder. We had good links with our schools and with the teachers because, as you know, in ADHD specifically, there's need to liaise with the teachers, classroom management, seating, where the children are seated, how to treat children with ADHD is really important. So we ran workshops for children with the SENCOs. SENCOs are the Special Education Needs Coordinators. Every school has a SENCO. So we did workshops for SENCOs regarding ADHD management and psychoeducation groups. We did it also for parents. So this talk will highlight the importance of maintaining good mental health, and I will go through practical ways of setting up services within schools. And I will take you through some clinical vignettes. I know I'm a clinician at the end of the day. I did some research, but I'm really a clinician. And I know that colleagues like my clinical cases from my clinical practice. So I'll try to go more on those. So, be patient with me skipping some slides because of the time. Just maybe covering, many of us, when we hear the word mental health, we translate it into mental illness. It's sometimes a little bit, unclear. For me, it was unclear. Mental health is defined as the absence of problems and relies on good, positive, social, and emotional development for all. So mental health is really a positive concept. And the WHO definition is it's a state of well-being in which the individual realizes his or her abilities, can cope with the normal stresses of life, can work productively and fruitfully. I'll skip that too. Children and young people deserve to have a good start in life. Good mental health is key in children and young people functioning well in school and outside school. And as Ferdi was mentioning, we hope that maybe it also gives them resilience to cope in future life as well. Problems of most young people are psychosocial, social, and economic in origin rather than the psychopathological in origin. Mental health disorders often show the first signs in elementary schools aged children, but are rarely recognized as mental health disorders. So mental health and psychosocial problems often are the major factors affecting school performance and achievement. Children spend a good deal of time at school, and if we look at our memories or our friendships, one thinks of school friendships, because we did spend a lot of time in school, and school was a major factor in our lives. So it is also a major place to equip children with good skills to deal with life. Schools are, of course, easily accessible. There's no stigma attached to them compared to coming to a clinic or to hospital where we were based. We know that 50% of all lifetime diagnosable mental health disorders have an onset before the age of 14. So it's a good time, it's a good age to give our attention to. And schools are crucial in identifying mental health conditions. I always have, a child who has been through different schools, and then there's one teacher who's so skilled in telling them, I think you've got ADHD, go and see a specialist. And some of these children have been excluded, expelled from schools, and nobody actually picked up that they had an underlying problem. 12 to 22%, i.e. 1 in 5 of youth under the age of 18 years have a diagnosable mental disorder and are in need of service for mental, emotional and behavioral problems. However, 7% of affected youth receive the appropriate help. So we really see in clinics the tip of the iceberg, and there are so many that are maybe not making a fuss at school or not being problematic, so they are suffering in their own in silence, and they're not unfortunately getting picked up. So a whole school approach to mental health. It's not just, I know Fadi's research, it was researchers going in and you were training sort of teachers to undertake that, and that's very valuable, to have the teachers on board. So by providing them training, helping them to become, to do maybe simple CBT strategies, or for the counselor to do the work. I heard recently somebody saying we were teaching even teachers how to tell the children if they had bad marks, rather than you said, oh, that was a horrible mark, you did really badly. Telling them, I know you worked hard, next time you get better. So even the way you talk to the children is really quite important as a teacher. So, of course, we need to increase resources within the schools. Some community, I was just doing an accreditation visit in Bedford, that I was in the UK, and I was very impressed that they had lots of mental health workers being assigned to GP surgeries and going into schools. They had far better resources than we had in London, in fact. And then combining school and community resources, i.e. camps, clinics, GP surgeries. They have some mental health workers going to GP surgeries. So it's really developing a partnership. And this partnership is easier said than done, because we all belong to different organizations, and being in partnership is never easy, because somebody's under education, the other organization under health. So these partnerships, it's really up to people. It's usually when people get on, they sometimes happen, and you find it really going well. So mental health services can offer expert mental health training at schools. We used to, for example, go to special schools to provide liaison work. So we would sit with the teachers, they would discuss in an anonymous ground the students, and say, I'm worried about, because we had to take permission from the parents if we went in to discuss the children. So they would discuss, I've got this problem, what should I do? And without mentioning the name of the child, would say, maybe try this out, try this behavior program, or do this reward. And sometimes they take it on board and work on it and don't bring it back. And sometimes they have tricky cases where we would say, I think this case should be referred to us. So they would then get permission from the parents and would refer the child to us. So in a way, it was a good way of using resources, because it meant that they didn't have to refer every single child they were worried about. We also empower them to deal with some cases. So we can, I'm just going through some slides. So what can schools offer? They can provide programs to promote social emotional development. And like the program actually that Fadi had, the teachers can provide that. That's great. And providing services that intervene as well. So intervene with anxiety problems for individuals, how to cope with anxiety, and emotional problems. The research indicates that integration of wellness program within schools can provide valuable mental health care to school children. So mental health in schools includes students with diagnosable problems, therapy and behavior change, and connecting community mental health providers to schools. Now, we need to build the capacity of school staff. So what are specific issues, for example, that school can address? Bullying is one of them. Some schools are very firm with having zero tolerance to bullying, and that could be addressed in school assembly when the the children all have an assembly once a week at school where somebody talks, one of the teachers talks about the school, and if bullying is reported, it's taken very seriously. And helping students cope with pressure of exam testing. You know, I know some schools I work with, they have very high standards. They really don't care that much about the emotional state of the children. They're so academic, you know, and some children go under and they have to, parents decide to take the children out of school. So I think these, you know, looking after their well-being is very important, especially in under exam pressure. Now I really like, and I know Fadi mentioned using the Strength and Difficulties questionnaire, and that was developed by my colleague Robert Goodman at the Maudsley. I can't emphasize more how lovely this questionnaire is. It's free, downloadable on the internet, and it's available in Arabic, in French, in English, in lots of other languages. So, because sometimes as a clinician I don't have time to go to schools to find out about the children, but actually through the questionnaires to the teachers, and you can use it in Arabic, give it to the parent, and I usually tell the parent, bring it back next time to the clinic. And I'm quite, you know, in Dubai, for example, where I'm working, teachers really give their time to make notes, you know, and to make their observations. And if I put the child on medication, send a questionnaire again, they actually write back, oh, he's fantastic, he's doing so well. You know, I've never met that teacher face to face, but I got feedback, and they know I'm communicating with them. So I put up the strength and this is the T for teacher, that's the English form, and that's the Arabic one for teachers, and then there's also one for parents, and this is the self. This is for young people to write about themselves too, to fill the questionnaire themselves. And you can compare also, you can look up outcomes. So you can have, at one time point, having the questionnaire completed, and then 6 months or a year later, you look at the scoring and see whether there has been improvement. And it's quite nice for parents and the children to see, actually, I'm in progress. You know, I'm not scoring as high as I did before. So it's a nice way of getting feedback. Now, exclusion is another one, and I know my colleague Tamsin Ford, she did a lot of work regarding school exclusion. Excluded children can develop a range of mental disorders, such as depression, anxiety, as well as behaviors. And the impact of excluding a child from school on their education and progress is often long-term. Now, I dealt with children with ADHD plus conduct disorder plus oppositional defiance, so it wasn't uncommon at all to either have them excluded or expelled. They're not allowed to go to school, and then they're home for 3 to 4 months until another school is found, and it was disastrous. And I was living in an area where they have gangs, so it was a very good opportunity for that child who hasn't been in a gang yet to join a gang and learn more difficult behavior. So, I was going to go through a vignette. I'm going to skip those. Of a child who was referred to me. I remember we were a very small team, very limited resources in the clinic, and we really got so many referrals that were not appropriate. So we decided as a team to have our screening questionnaires sent first, and then accept only the ones that fitted within our clinic. Because it was unfair to get somebody who didn't have ADHD or likely to have ADHD. They had to wait on the waiting list when we had somebody else where we thought, no, it's not appropriate, but after having seen the patient. So it was a referral. At the time I was at Guy's Hospital, referred to ADHD clinic at Guy's in London, boy 10, 8 years, screening with SDQ, because he scored everything. He scored very high on the SDQ. So I saw him in the clinic, and the teacher then accompanying him, she said, Dr. Abd, I know he hasn't got ADHD. I ticked all boxes in the questionnaire to get him into a clinic, And because this is his last day at school. He's been permanently expelled from school. And she really wanted him to be seen by mental health services. So I liked her frankness, because she was like, telling me she falsely completed the questionnaire. And now, and later on, I valued her decision as well. Because she knew that because this was his last day at school, this was his last day of getting, sort of being seen by the teachers, and that it's going to be quite detrimental for him being expelled from school and staying at home. And she felt she had to do something, and that's the best she could do. Tick all the right boxes in the questionnaire and get him to be seen by our services. She did the right thing, really. Then I had another child where it was a 15-year-old boy referred to the clinic by a teacher after he moved 3 schools. This was his 3rd school. And it was only in the 3rd school that one of the teachers told his mother, let him be seen by somebody regarding ADHD. I think he's got ADHD. So he came to see me with his mother, and I did diagnose ADHD. The mother was actually very cross, because she said, it has been such a traumatic experience to be asked by 2 schools to leave. He goes, settles in the school, and then he's asked to leave, when he actually did have an underlying condition. Now, this young person wasn't overactive and disruptive. He was daydreaming a lot in class. He did go to a private school in London, so he was not abiding by the rules. He always did forget things or forgot things from to get his games kit or put the right shirt on, or didn't always wear the school uniform or the right socks, So the school got, they thought he was just intentionally doing it, when actually he wasn't. He was really having difficulties doing it all. So the mother actually said, I'm going to go and tell the other schools that, look, he did have an underlying. She was really quite, she was, I don't know, if you have children, if you had a son or daughter and you had to leave school, which I had to, it's really quite traumatic for the parent as well, if you have to take your child out of school. Very upsetting experience, because you also make friends with the parents, and then suddenly they tell you, you've got to go. Right. There are programs available. The one I was trained on is the Incredible Years program for teachers. It's also got a parenting program by Caroline Webster Strappin in the States. We know that randomized controlled trials in primary school in England from 4 to 9 years, the old SDQ was better at 9 months, greater effect for worse children. That was the work by Tamsin Ford, who was also working at Guy's when I was there. She's now, I think, in Cambridge. And then Stephen Scott mentioned some of his work as well. So really, even when we use parenting work, some of the parents, when I used to tell them, when we explained we're using praise, reward, problem solving, and parents said, yes, we know that my child gets these stickers in class. So some schools are very good at implementing stickers and rewards, and it's important to do it with the parents as well. I like, to extend that to the home too. I think you have a teacher's guide for the research, which is very helpful. Psychoeducation regarding ADHD for schools. I have a handout for schools, and which I did with Professor Eric Taylor at the Maudsley, one for school and one for teachers, for parents. And we have a book, the same guide actually includes classroom management for ADHD. And that includes, for example, sitting at the front of the class. Actually, I have to tell you,